Welcome to Let's Talk Antigonish, the podcast where we sit down with neighbors, experts, and friends to explore the stories, the questions, and the big little issues that shape life in our town, one conversation at a time. This week we're talking to Dr. Gord Simms about life as a family doctor in Antigonish. Hello everyone and welcome to Let's Talk Antigonish. It's me, Justin, all by myself. Brendan has gone back up north to teach. Anuj is still in India, and so I am alone in the studio. But for my guest, Dr. Gord Simms. Hello, good sir.
Hello.
So we have a confession to make, the two of us. Is we recorded this interview already yesterday, and then when I went to edit it, there was something wrong with the file, and so it was completely lost. So we've already had this exact conversation we're about to have. So this is like a rehashing of the same thing.
Yeah, I mean, it's my second time on the podcast now, so I guess I'm officially a friend of the podcast.
You're a returning guest. That's exactly what you are, a friend of the podcast, returning guest. So I'm going to ask you a lot of questions that I already asked you, and we're going to both pretend to the audience like you've never heard this before.
Well, now I know what's coming.
Exactly. So yeah, your questions should be, or your answers should be better at this time.
We'll see. Yeah, no promises.
So thank you, audience, for indulging this sort of play acting that we're about to do as if we've never met before and I know nothing about Dr. Simms. So here we go. Dr. Simms, hello.
Hello.
You are a family doctor here in town, but you're also a hospitalist, and you will also have a PhD in, I believe, biochemistry. So there's a lot to your history. And before you tell us how you got into family medicine, tell us what a hospitalist is, because I know people do not know this term. I was slightly barely familiar with it when we talked about it yesterday. So what is a hospitalist?
Yeah, most people don't know what a hospitalist is. So it's a fairly new model in Nova Scotia. Now, 10 years ago, family doctors would round on their own patients in the hospital. So if
round means they go... So like you see your patient who you sent to the hospital, and then you'll pop by and visit each patient.
Yeah, exactly. Yeah. So each patient needs to be seen every day. So if you had 3 patients in the hospital, you would see those patients, check their vitals, do your assessments, see if anything needs to be changed. You'd just manage them in the hospital.
And those are your patients?
Yeah, okay. Those would be your patients. And then you'd finish up when you finished up, and then you could start in the office and see your family practice patients. So that became quite burdensome, and because you're essentially on call all the time and you don't really get any time off.
Yeah.
So they switched to the hospitalist model. Now, the hospitalists, some of us are family doctors, some of us are internal medicine trained, and we basically will do a 7-day shift in the hospital, and we will accept new admissions from the emerge doc. So if you went to the emergency department and were sick enough to warrant admission, they would hand them over to us. We would accept you as an admission, and then we treat whatever issue's going on. And if we don't know exactly what's going on, we're going to investigate that and maybe call some specialists for help, with the end goal of trying to fix things as quickly as possible to get people home as quickly and as safely as possible.
So the ER doc's like, okay, this person needs to go to the hospital to like stay overnight in a bed and be looked over by somebody. So you're essentially the primary physician, the first contact for anyone who's in the hospital for whatever reason, determining who needs a specialist and what sort of tests. So
we become the MRP, the most responsible physician.
And the MRP, sure. Okay, so that's essentially a second job on top of your family doctor job. You're doing 2 jobs.
Yeah, so I do 0.5 hospitalists, 0.5 family medicine. In theory, I actually have more than a 0.5.
Right. And does that mean you have, therefore, fewer patients, like on your roster as a family doctor?
No. I have...
So you have a full contingent.
I do, yeah. So in Nova Scotia Health, in the Department of Health and Wellness says that for you to be a full-time family doctor, you have to have a roster of 1,350. So if you're a half-time doctor, you would have half of that, right? So 675 patients. So I'm hovering around 700 to 750 patients right now.
So
probably closer to a 0.6, yeah.
So this is the question I didn't ask last time, but how do family doctors get paid? I mean, I'm more familiar with the state, how it works in the U.S., because you do have patients and you see them for a certain amount of time. Are you billing Nova Scotia Health? Do you get a salary? I don't actually know how you get paid.
Yeah, there's actually a few payment models. The classic payment model is billing, and we call that fee for service. So anytime a patient comes in, whether it's a regular visit or a geriatrics visit, there's a billing code that's associated with that. And we essentially submit that to MSI and then would get paid for it. More recently, to kind of address some of the issues with burnout and accounting for work that really isn't encompassed in billing fees, the province has offered something called the longitudinal family medicine contract.
Okay.
So that essentially takes into account, 1, your panel size, 2, how many hours you've worked in the week, and 3, the types of cases you've seen. So the actual billing codes, as well. So all of this stuff gets submitted by us every week, and then they do the calculation and give us a payout.
Okay. So a family doctor, what specifically is it that you do? Because you are treating children in your clinic, but you're not a pediatrician. You are treating folks who are older who deal with issues of gerontology, but you are not a gerontologist. Is that the right term?
Geriatrician.
Geriatrician. Is gerontologist a word that I just made up, or is that from like the UK?
I should have looked this up after our conversation yesterday, but I didn't.
Gerontologist.
It sounds like it's a word.
It sounds like I don't know why I would. Anyway, geriatrician / gerontologist. So, but you know a little bit of everything, I assume. So what exactly is a family doctor? What differentiates you from those other kinds of physicians?
Well, I think first and foremost, we're the first point of contact, or should be the first point of contact with the healthcare system, right? So we're here to answer questions if new things come up, or you get injured, or a new illness. That's the kind of stuff we all think about when we think about family medicine.
Yeah.
But we do a lot of other things like preventative health care, and making sure we're all up to date with our screening, and making sure that our blood pressure and our cholesterol are where they should be.
So these are like checkups, like people come in, they don't actually have a complaint. You just want to see them to make sure they're doing okay.
Yeah.
And so you, as I was mentioning before, your CV is long and complicated. You are currently a family doctor and a hospitalist, but you did not start out at university with that as a goal at all. And then you actually went on to get a PhD in something sort of related to clinical work, but not really. So just give us a brief recap of how you came up in the world and then eventually landed on family doctor as the thing you want to be.
Sure. In first year university, I really, to be honest, fell in love with chemistry. I really enjoyed being in the lab. I really enjoyed the challenge of chemistry and the complexity of it, which is kind of a theme through my life. But I finished an undergrad, and then I was asked by a gentleman, Dr. Donald Weaver, to do a PhD with him. And interestingly, he's a neurologist, and he worked with, or he still works with diseases like Alzheimer's disease, epilepsy, and he asked me to join his group. And around this time, I was sort of developing thoughts of wanting to maybe pursue medicine, but I was really wanted to fully suss out what research meant to me and what that would be like. And I started with his group, and I worked on a project focused on Alzheimer's disease. We were developing small molecules to try to stick to something called amyloid beta, a protein associated with Alzheimer's disease, and trying to stop it from gumming up the brain, so to speak.
Yeah. But you weren't dealing with patients at all at that point. You were a guy in a lab mixing chemicals and whatnot. So you weren't like out there meeting a patient, right? You were completely by yourself at a bench.
I was always in front of a bench or a computer or an NMR.
Right. And so how did you go from, I said this last time we were interviewing, it's like the opposite in the sense that you're working almost by yourself, where you don't talk to people, you're interested in medicine, sure. And then you become a family doctor, who I feel is your job as a family doctor is to have the most amount of contact with a patient. I mean, if you're doing like sleep studies or something, or a surgeon, like you might have some contact, but you have constant contact with humans, the opposite of what you were trained to do in a way.
Yeah, so I I really enjoyed research, but I think part of the aspect of the research I was doing that I missed was that human contact and that human connection. I'm a pretty social guy.
Yeah, you seem friendly. You seem like you should not have been stuck in a lab somewhere. So good choice.
Lots of friendly people in labs, but I wanted, and we sort of touched on this yesterday, but with research, there isn't that instant gratification, right?
Oh, that's
and
right, yeah.
it takes, especially in molecule and drug design, it takes decades to get from an idea to an end product that helps people.
Yeah, you could design something that went on to become a drug that did finally help someone after all the clinical trials or whatever. So 20 years later, they come and shake your hand and they say thank you.
Yeah.
Whereas if you're a family doctor, 5 minutes into the thing, they'll be like, "Oh, thank you for diagnosing me." So it's instant gratification.
Yeah, exactly. and just I like fostering and building relationships with people. So it seemed kind of like a natural idea. So I pursued medical school and after a couple attempts got in and now
After
we're
a couple
here.
attempts, you didn't get in straight out of the gate?
Not out of the gate, no.
Really?
I
Which
was-
is because there's a. Did you have to take that? I forget that exam to determine how good you are. Essentially,
Yeah,
with
the
it.
MCAT.
Is it that what it is?
Yeah, MCAT. Yeah.
Not the MCAT. That's the one where like, how was your knowledge of like? But there's another one. It's some sort of personality kind of test. Maybe they didn't have it when you're doing. I can't remember the name of it. Or is it the MCAT? I
Yeah,
thought,
that's what when I wrote it, it was the MCAT, and there's certain like different topics that you'd go through.
Yeah.
Chemistry, biology.
I assume you did well on
psychiatry.
chemistry.
I did fine on chemistry. Yeah,
So why did you not get in? Just because it's highly competitive and they can't take everybody?
I think that's pretty much it. I feel like most people don't get in on the first try. There was
Okay.
one of my classmates was 5 tries, and they finally got in. So it's very highly competitive.
It's interesting because I'm just saying this because you seem like you were thriving and you were more you were meant to be. So it's strange that you got filtered out at the start.
Maybe I interviewed poorly.
Well, you're doing a good job so far. So you beefed up your interview skills. So you're a family doctor, and we talked about this last time because I was thinking like, I imagine a lot of the people you see are people who have the most amount of problems, and who are the people with the most amount of problems? That would be older people. So, and you quoted to me the average age of your patients. So can you just tell us what is a standard average patient in your clinic?
Yeah, so the median age of my patients is somewhere around 72 to 75.
Yes,
So
it's older.
yeah.
Yeah. But nonetheless, you're still seeing, like, you're a family doctor who takes on anyone. So if someone comes off the registry, and they could be any age.
Yeah, so I have patients that are on the order of months old. I have a couple patients that are 100 years old. So it spans the whole life cycle.
And I can say my daughter we registered her with a family doctor when we got here like 11, 12 years ago. And she never went to the doctor because nothing was wrong with her. And after like a decade, we found out when she finally did need to go, like she'd been knocked off the system because they're like, oh, she maybe doesn't live here anymore. So I'm sure you have people who've registered who you probably have only seen once at an intake or something.
Yeah, no, there's people that I have registered that I've never seen.
Seen.
Yeah. So not many, but I saw a piece of imaging this morning. I was like, who's this patient? I did some digging, and it's a patient of mine.
So I asked this last time because I know this is a question on people's minds. So you have the official name is the Need a Family Practice Registry. So if you do not have a physician, family doctor, you go on this list. And it's sort of first come, first serve. If you're on the list and someone's available in your area, you go to them. But is it possible that you can take on a patient who's not necessarily on the list for some reason? Do you have, as a family doctor, the power to let anyone onto your list of patients?
Sure. It really is at the discretion of the physician and whatever contract they sign when they settle into their practice. So when I started here 3 years ago, there was a certain amount of patients they wanted me to take from the 811 list. I took a certain amount of patients from another physician that was retiring. Mm-hmm. And the rest of my patients I have essentially picked up as a hospitalist. So when I was rounding, if there's people that had quite a lot of illnesses, no family doctor, I typically take those people on, which explains why the median age of my practice is about 75, 72, 75, yeah.
So I know we talked about this last time as well, but you seem like someone who's quite interested in the more complex cases. And complexity meaning maybe there's a number of problems happening in diseases. Is that is that the case? Do you like complexity?
I really enjoy complexity, and that's really, I think, what spurred on my passion, because everyone's family practice looks different, and every family doctor has different interests. And I have a particular interest in chronic disease management.
Oh, interesting.
Yeah, so
which is the most difficult thing, I would imagine. I mean, everything is difficult. You have someone who's terminally ill, but like if you're dealing with somebody for 20 years with ongoing complaints, and they are looking for relief, and you can't provide it, that must be difficult.
I don't think it'd be fair to call it the most difficult thing, because every interest has its challenges, whether you're working with addictions, mental health, palliative care, chronic disease. They all come with their challenges. And that's why the family medicine model is so nice, because people can pick up specific interests in certain models. And these days, family doctors don't just do the office full time. We all have other interests, and we all do other things, whether it's an addictions clinic or hospitalist.
Is that the case? That's interesting. So you're hospitalist, obviously, is your other thing.
Yeah.
But so you're saying most family physicians have a little side hustle of area of interest?
Yeah.
Interesting.
Yeah. So, sports medicine, I work with Dr. Alison McGlashan. She's in the clinic with me. She's her and David Cudmore are both very into sports medicine, so they travel around with various teams. Alison McGlashan does a lot of work with Rugby Canada, for example.
Oh, okay.
So, and she does a lot of work at St. FX with the athletes over there. So we all have our other interests, whether it's low-risk obstetrics, delivering babies. That's a common one. Hospitalist, sports medicine. I do really enjoy chronic disease management. I also do a lot of lumps and bumps. So
lumps and bumps.
Yeah. So taking skin cancers off of people and doing minor procedures like IUD insertions, toenail removals, things like that.
You're into toenail removals.
Well, for ingrown toenails, if you can't manage it, then sometimes it has to come off.
Fair enough. Oh, so there's a little bit of you that likes the surgeon side of things, it sounds like.
I love the tactile, the piece of medicine. Yeah.
Fair enough.
Working with your hands.
So there's another few questions I want to go over that are very common for people dealing with family doctors or who don't have one. And that is many family doctors that I've spoken with, I've interacted with, they have this sort of rule of if we have a 15-minute appointment, I can only talk about one thing. Like we only have time to get through one issue. I can't talk about 50 different things. And that sort of becomes a hard and fast rule. And can you just tell us why would a physician adopt that, and how do you approach that? Because it sounds like you're dealing with, if you're dealing with someone who's 75 and they have a lot of issues, you can't really stick to one issue. So tell us about that.
Yeah, so I can see why family doctors do that. When we start adding on a second, a third, a fourth, a fifth concern in an appointment, your day can get very long very fast. And I tell patients this, right? So if we have a 15-minute interview and I'm seeing 25 people in a day, an extra 5 minutes at the end of each appointment adds 2-3 hours onto the day, right?
So then that means people are waiting.
Exactly. And, usually there's some amount of waiting at a doctor's office. If there's something that's really urgent that needs management right now, I can spend 45 minutes with the patient because we need to make sure that they're safe. But typically when a patient comes in, my approach is more so, what's your list today?
Yeah.
And here are the things I'd like to talk about. And then we sort of have a negotiation of the things that we can address with the time that we have. And, some things we don't have to talk about right now. Because when you have a 15-minute appointment, we're going to talk about what the issue is. I'm going to ask some clarifying questions. I might prescribe a new medication, so I have to talk to you about what the side effects of that medication is. I might have to do blood work and an x-ray and maybe even a consult to a specialist.
Yeah.
And then I have to also write your note for that interaction.
So that's all happening within a 15-minute window.
Ideally.
So because at the end of it, you have to write up everything that just happened and then send out requisitions and whatnot. So
Yeah.
So really, you can't spend the full 15 minutes. You got to spend them closer to 12, and then like quickly for 3 minutes right up there. Is that what's happening?
That's what's happening, yeah, and that's why you wait sometimes at the doctor's office, right? Some people will take the approach of doing their notes at the end of the day.
Okay.
I try to shy away from that because I don't want to forget details which are important to keep in the note, because accurate notes are better for patient care and patient safety. So, it's doing a note 6 hours later after you've seen another 20 people. It's difficult to remember all of the details.
My bad.
And it's really important to remember all the details.
Yes, I would imagine so. So if you're a patient and you're waiting in the waiting room for a while, we should be aware it's because you are spending time with each patient, and sometimes you need an extra 3 minutes to write up a note or something, and so that can stack up at the end of the day. But from your perspective, is there a level of stress knowing that there's people waiting and knowing that you actually do want to spend more time with this patient, but maybe you can't because of the way the day is unfolding? Is that a constant source of stress?
It is a constant source of stress. Yeah, you can ask the staff at the Mediplex.
Yeah.
My apologies.
Oh, no. Oh, I suppose because they're the ones. We talked about this with the ER docs.
Right.
Because people are waiting and they're like, do you ever hear, we asked, do you hear complaints? And like, well, we don't. But the nurses, the triage nurses certainly do.
Exactly. They're the one that bear the brunt of it, right?
Yeah.
But yeah, it is because, I don't want to keep someone waiting for an hour. I know we all have very busy lives, and I know how much I dislike waiting for an hour for any appointment myself.
Oh, for sure.
So, like I said, part of it is going to happen. If someone comes in and I think they might be having a heart attack, I'm going to spend 40 minutes on that.
Makes sense to me.
So, but yeah, there's a certain element of stress, and I try to build breaks into my day that if I do go over, I have a 15-minute catch-up time, right?
Smart,
so
yeah.
I still do build those into my day, but your day can typically get it away from you sometimes. Some days I'm on time the entire day. Those are the exception, though, not the rule.
Yeah, I understand. And so the admin who's making appointments, do they have a capacity for triaging which of your patients call in who should see you sooner? So, normally you might have to wait 4 or 5 weeks, but if somebody's got a complaint that's not an emergency, but it seems important, they might be able to slot them in for a sooner appointment. Is that part of their job as well?
Yeah, so most doctors, they build their schedule with the capacity to see people the same day. So we usually have 2, 3, 4, 5 slots during our day that aren't booked ahead of time. And if people call and need something urgently in the next day or two, then we can facilitate that. But yeah, the staff does a lot of triaging, right? They understand. I mean, they've been working in the clinic for many, many years, and they have grown to get a sense of what things need to be seen really quickly, what things don't. And if they ever have confusion, they just ask us and say, how long does this need to be seen in?
Yeah.
When I'm reviewing my labs and my blood work and I see something that's urgent, I'll send a message to the staff saying, can we see this person tomorrow or the next day? Versus we can talk about this when we see them at their next appointment in 3 months, right?
So that is so if I'm waiting to hear back from my physician because I did some blood work, for example, if I don't hear from them, it's not because they haven't looked at the blood work, but it's because they probably looked at it and they said there's nothing urgent, therefore we can talk about it in a few weeks' time. Is that what?
Yeah, for a lot of people, but if there's ever concerns, always call your doctor, right?
Yeah.
And it never hurts to close the loop. I know my personal practice is if I've done some sort of imaging and it's fine, or your PAP comes back negative, or I get the staff to basically say, this is fine. And if you need to talk about it, you can book in, but there's no issue with your blood work or your PAP or
so
whatever.
The staff
result.
will call and mention.
Yeah, exactly. Or if I take off a skin cancer and it actually is a skin cancer, they'll call and say, Dr. Simms says it was a skin cancer as expected, but he got all of it. Right?
Okay.
So they'll call and close the loop with patients.
Very helpful. Do you find a lot of your patients end up maybe they called 811 because they wanted to get in with you, but they had to wait a little bit and they weren't sure. And so they either call 811 or go to the emergency room for some reason, or they use the Maple app. Are a lot of your patients trying to get care before they can get an appointment with you? Is it a normal thing?
Yeah, I mean, my wait list these days can be 4 to 6 weeks.
Yeah.
Which
is kind of standard, I think, right? In Nova Scotia.
I think so.
Yeah.
I mean, there's some doctors that are less for sure, and there's some doctors that are far more, right?
Oh, gosh.
You know, we have doctors that have 3,000 or 4,000 patients as opposed to 675, right? So, it's I would say that's probably pretty standard.
Yeah.
The 4 to 6 weeks.
And people who use like the Maple app, because that's something I've considered, where I had a quick question for my physician, but they weren't available for 4 weeks, so I just talked to a physician. And that's not weird to you?
Well, no, emergencies happen, right? If you have chest pain, you should go to the emergency department, right? Or call 911. If you've broken your arm, that's an emergency, right? You should go to the emergency department. And sometimes patients can't get in with me and they have, if someone calls and they have a fever and a sore throat, I'll typically accommodate that. But sometimes they'll go right to the emergency department, which I don't think is a bad call either. Now, Maple, all of us have the opportunity to go to Maple 2 or 3 times a year. That's part of our coverage that we have in Nova Scotia, or you could do virtual health. And if someone can't get in with me, I think that it's very reasonable to for them to go to Maple. The limitation there from my perspective is I don't know what that doctor talked to you about, and I don't see the note that they generated in the interaction with you.
Yeah, let's talk about that real quick, because that's a question I had actually asked Nova Scotia Health as well, do the physicians on Maple have access to my full patient history, and whatever they do, does my family doctor see that? So what is the status of patient records in terms of who can find it, who has access to it? Like, do the Maple physicians see everything and vice versa? And how does that work with pharmacies and the hospital and specialists?
Yeah, it's quite piecemeal right now. And on November the 14th, our zone here, we're going to roll out the one person, one record. And they've already rolled that out in the IWK and in central zone Nova Scotia. So the province is broken into 4 zones.
Okay.
And that's going to be a cohesive medical record where it doesn't matter if something happens in Sydney or in Yarmouth, I'd be able to get access to imaging, blood work, letters, you name it.
Mm-hmm.
And
so
now,
that's not the case now.
No, it isn't. It's actually quite piecemeal. Yeah. So, in my practice, I have access to St. Martha's Regional Hospital. Their admission records and blood work and imaging done there, or any of the hospitals in this area, right? In Guysborough or straight Richmond, for example.
So you can just log in and see anything.
Yeah. So that's the hospital-based medical record. And then if I want to see something from Halifax at the QE2 or the VG, then I'd have to log into another electronic medical record called Share. Mm-hmm. And that's how I can access those, whether it be imaging or blood work. And then, we have a separate record for prescriptions. We have the drug information system here in Nova Scotia. So I have to log on to that to see who's prescribed you what, how much do you have left, did you even pick up the prescription, right? If I wanted to show a patient an x-ray to go through it themselves, that's another thing.
System. My gosh, that's I can see why they're trying to switch to one system.
Yeah. So, and then we have our own medical records that are different than all of that. So our records are kept on our own electronic medical record as well.
Okay. And then you don't have access to Maple, it sounds like, and whatever the physician did there, unless they ordered it from St. Martha's.
And that Maple physician might not have access to all of the same EMRs that I have, right? Because if you have a Maple physician from Ontario, they might not have access set up for, Meditech at St. Martha's Regional Hospital to look up those images, those tests, they wouldn't have access to any of my notes, right? So there are some real limitations, but if there's something acute going on and you aren't able to get in with your family doctor, that's a really reasonable option.
Sure.
And I want people to empower themselves, so doesn't bother me if you go to see another doctor for an acute issue.
Sure. And but the new system is going to try and make that so that you're all just logging into one spot and everyone has access to everyone ideally?
Yeah, with the exception of the family doctor's electronic medical records.
Like your personal records,
our personal records, that'll still be its own record.
So you have this concept of the health home clinic, which we heard about from, I think, Michelle Thompson, when she was here speaking about it. And I think there's one or two of these here in Antigonish. And this is correct me please if I'm wrong, it's sort of a collaborative practice where you have physicians, but also maybe nurse practitioners, other folks there. And so you're not registered with a single doctor in a sense. You're registered with the clinic, so you can see whichever doctor is available, or if you don't need a physician, you can talk to a nurse. Have I correctly explained that? And is that what your practice is?
Yeah, so what you're describing is what we call collaborative practice, and there's a brand new clinic that's been built. It's up by Access, Nova Scotia. I actually haven't even been in that clinic yet. I'm still at the Mediplex on Church Street.
Yeah, we hope to do an interview with those folks up there because we're really curious.
Yeah. So at the Mediplex, we're, I would say, quasi-collaborative. So collaborative means that a group of doctors shares a pool of patients, and no doctor is ultimately responsible for any patient. We are, I like to call it quasi-collaborative, where we have our own patient rosters. My patient is my patient, your patient is yours. But like I said earlier, we keep spots open, and we'll see each other's patients for urgent things, right? So if one of the other doctor's patients has a fever and a sore throat, I'll be able to fit them in, and I will manage that acute issue. And if there's anything that needs follow-up more chronically, then having them follow up with their own family doctor.
Yeah, that makes sense. So do you prefer one model over the other personally? And do you think one model is better objectively than the other?
Well, I've never been in a truly collaborative practice. I think there's benefits to that. Mm-hmm. If you're in a truly collaborative practice, it makes going on vacation much easier, right?
Yep.
Because there's someone that's, keeping an eye out for blood work, keeping an eye out for imaging. And if you go away, you don't need to look at your inbox of blood work and results that are coming in. For me to go on vacation, if I want to go for more than a week, I certainly need to make sure I arrange for another doctor to cover my practice.
Yeah, like a locum.
Yeah. And, I typically would still watch my own inbox. So I'd still typically manage my own, or watch blood work results that come in and imaging results.
So while you're on vacation, you're looking?
Quite often, yeah.
Oh,
sometimes we cover each other.
That's not a vacation.
It is my vacation.
Oh, man. Yeah, I understand, because you're invested in your patients, I imagine. Like, you're emotionally interested in their health. When you've worked with a patient for 2 or 3 years, you really understand the intricacies of their disease, what you've tried, what's worked, what hasn't worked. And sometimes it's a little difficult for someone to jump into that cold and, be able to deal with an issue, right? So in a collaborative practice, you have shared notes, and so there's a little bit of, you get a little bit more reprieve. I think the flip side of that is, I am fairly particular in how I want to manage people and sort of the processes that I have in place. And if you don't have someone that's on the same page with you, that could be challenging. But again, I can't really speak to it too much because I've never participated in a purely collaborative model. So there's some personalities as a physician for which it might be a better fit than others, which is why not everyone is clamoring to suddenly start one of these collaborative clinics, because maybe they prefer being more independent.
Yeah.
Okay.
I think it's reasonable.
Makes sense. Physicians are humans too, it turns out.
We are, yeah.
So, what is it that you enjoy most about being a family physician? Because you could have chosen any discipline really within medicine, and you were drawn toward this. What is it about it that you find the most satisfying?
I think it's the longitudinal nature of it, right? You develop relationships with people. You get to know what their values are, and they get to know what your values are, and you can make really lovely lifelong relationships with people. And I really love advocating for people. The system is very strained right now, and access can be very difficult, even with a family doctor, right? And trying to ensure that people get the best care, it's something that I really, a lot of the family doctors strive for, and I know I certainly do. So, I think I like the relationship building, and then the complexity of someone that's been collecting illnesses over the course of their life.
It's a very positive spin, collecting them like Pokemon. But so let's then talk about some of the challenges. I also want to talk about Antigonish and physician recruitment and things like that. But let's talk more generally about, as a family doctor, burnout is a thing that happens even at a young age for a physician.
Yeah.
What are the contributing factors toward people saying, I can't do this anymore, I have to take a leave of absence, or just I need a career shift? What are the stressors for you?
Well, I think I partially alluded to some of it. We have our 8 to 6 or 8 to 4 or whatever you want to call it, but there's always the inbox, which is always coming in every single day, right? Whether it's consult letters from specialists you have to read, blood work, imaging, letters from the Victoria Order of Nurses about what do we want to do in terms of care. So that's a never-ending avalanche, right? And that can be kind of overwhelming, right? And if you don't look at your inbox for 2 or 3 days, it can get very large, right? And then trying to find the time to catch up on all that and already meet your other clinical obligations can be quite challenging, right? So, even though we have a quote 8 to 4 in the family office clinic, there's typically another 2-3 hours a day that you're working every day, right? So weekends we're always on. If someone from a specialist calls on a Saturday, I'll answer that, right? If while I'm in a busy clinic, if a specialist calls, I'll answer that, right? And there's a lot of paperwork, and that can be quite challenging getting that done in a timely manner and back to people.
I'm trying to think of another profession that is similar, because you're dealing with, a constant deluge of paperwork and emails. A lot of people have to deal with that and don't take weekends off. But then you're also dealing with emergencies, in a sense, like things that, like a specialist calls you and tells you something about a patient that you then have to deal with that quickly. So you're both dealing with a constant stream and constant emergencies. And I can't think of another profession for which that is the case, because most people have the capacity to take breaks, and it doesn't sound like you can do that. Like you said, you're on vacation, you're already taking emails.
We can, though, to be clear, right? But it can be difficult because you need to find a physician to cover, right?
Yeah.
And that's can be a unicorn sometimes.
So, but is that what leads to physician burnout? Is that constantness of it?
Yeah, especially if you're doing other work as well, right? So, for example, during a hospitalist week, if I'm seeing 25 people a day, I have to see those 25 people, right? And I also have to manage my inbox. And, if an urgent blood work result comes in for one of my family medical patients, I'll have to deal with that.
Yeah.
So quite often, I'm calling family medical patients even during my hospitalist week and, arranging IV fluids at ambulatory care, or they need an iron transfusion or a blood transfusion, and you got to arrange that as well while you're trying to manage your hospitalist patients, right? So, during a typical hospitalist week, I'll work over the course of 7 days, 90 hours, and that's fairly standard.
That's fairly standard. Well, you were telling me before about some of your hours, and you're very youthful looking, but you're not 20, and so
I'm certainly not 20.
No, and so the hours that you talked about working blew my mind in the sense that I can't, like, if I had to stay up until 1 a.m. these days, I feel like I would be paying for it for the next 5 days, being tired and incapable.
Sure.
And you're like, yeah, well, and then you're like, one day I worked as a hospitalist and then stayed up all night, and then I started again the next day without sleeping, doing more hospitalist stuff. Like, what are those insane hours, and how do you manage to keep sane while working all this stuff?
See, that's my secret. I'm always tired.
You don't look tired. You're always tired, but I know there's no way that, I mean, you're still dealing with really complicated cases, so your brain is still functioning at 100%.
I mean, no, I mean, there's lots of studies that show if you're sleep deprived that your decision making goes down, right? And after, I think it's 48 hours of no sleep, it's equivalent to being intoxicated, right?
Hallucinating. Yeah.
So, to manage the burnout, I find it very important to make sure that every 3 months I take a week off. Mm-hmm. And that's something I've started to incorporate. Exercise is up and down for all of us. I really try to make sure I lean into exercise as well because, that's really helpful for me. Well, it's really helpful for all of us, but definitely helps with the mental health and the physical health. So, do a lot of exercise. And I have to say I'm very lucky that I have a very supportive and hyper-capable wife that really keeps the ship afloat at
Who's
home.
Also a physician, is she not?
She's an osteopath, yeah.
Osteopath,
so she practices as an osteopath.
Okay,
yeah.
so but she's also very busy in the clinical sense.
She is very busy, and we have a 3-year-old and a 5-year-old. So it's busy, but I can't complain. I live a blessed life, and there's a lot of love.
A 3 and a 5-year-old. It's just mind blowing. I think your average human being would listen to what you just said and be like, I do not have the capacity for that. And so you just maybe were born this way.
But this capacity is something that I've built over the last, I guess 10 years now of training, right? Yeah. So this isn't something that comes overnight. You build it, and I don't have to be this busy. I kind of choose to be this busy as well. So I have to recognize that.
That's true. So before we get on to physician recruitment and those sorts of issues here in Antigonish, last time I asked you, what is the thing that you would recommend for a patient that they do in order to remain healthy and avoid having to come in to see you? And I thought you were going to say exercise is the top of the list, and you did mention it now. But that's not what you said when I asked you. You used a different word. What was that?
Yeah. Well, I mean, lifestyle, right? And people are going to get sick, and lifestyle doesn't prevent everything. But, we take lifestyle for granted. And I think a lot of people don't have a sense of how much poor lifestyle can actually affect our health and our energy and make us feel unwell.
So what's under that umbrella of lifestyle?
Yeah, I mean, I typically break it into 5 things. So I would say exercise, sleep, hydration, diet, and then social interaction.
Okay.
I think those 5 things are so crucial to health and happiness. And, it's easy for 1 or 2 or 3 of those things to fall off.
Yes. So as soon as one of them falls off, you're increasing your risk that you might have to come see a family doctor, essentially.
Yeah, exactly.
And fair enough. So that's useful advice for everybody. Now let's talk about Antigonish. So you are from Nova Scotia. I think you traveled around when you were very young, but then you grew up in Dartmouth. Is that right?
Yeah, that's right.
Yeah. And so here you are in Antigonish, small town, rural hospital.
Yeah.
Why here?
Technically a regional hospital.
A
right?
regional hospital. That's right. But the big area, Guysborough and all that. Yeah.
That's right. So how did I end up here, sorry?
Yeah. How and why?
So my wife, Holly Simms, she's actually from Antigonish, and lots of family here, and And we moved here along with my father, actually, to Antigonish.
Your father came with you?
Yeah, he did. Yeah,
Fascinating.
so to be closer to family. And, Antigonish is a great sized town. It's lots of stuff to do for the kids, and really enjoyed the system here, and was excited to become a part of it. So there was lots of reasons that sort of led us to Antigonish, but family is a huge part of that.
Yeah, and so we have mutual friend Sarah O'Toole, whose job is to help to get physicians to see why this is a fantastic place to come to. So, and you work with her on this. This is a subject I think that's personal to you.
Pretty closely on a lot of stuff, yeah.
So when the two of you are out explaining to other physicians why come to Antigonish, what is it that you're telling them?
Well, there's a professional piece and there's a lifestyle piece, right? So, Antigonish for us and mine and my wife's experience, there's so much to do for the kids, right? Whether it's Fit for Tots or, the open gym at AEC or the pool or, there's just a tremendous amount of stuff to do for the kids. So that piece and being a university town, the culture here is really, it's there's a lot of energy, and there's great facilities like the gym at St. FX, and there's lots of beautiful places in nature to go hiking, and we're always finding new spots like Hemlock Ravine we just found.
What is that?
It's out Briarley Brook Road. There's a...
I don't know. Hemlock Ravine. I've probably been there. Does it have another name?
It's actually on a private piece of property. Yeah,
So
and it's more of a word of mouth thing, but
well, now the whole town has been listening. Everyone's going to be out Briarley Brookway looking for Hemlock Ravine.
That's right. So I'll leave the audience to go on that scavenger hunt, but that was a really fun. So there's lots of things like that. So it's a good sized town, and so we've really enjoyed that. And then professionally, I feel as a family doctor, there's a lot of resources to help support a family doctor, whether it be the heart health clinic, the diabetes clinic, that helps give us support, as well as our local internal medicine doctors. So, and the culture here around the family doctors is really special. Since I've been here in the last 3 years, we've recruited approximately 10 family doctors that are around my age, right? So it's a really youthful group, and even a lot of the specialists, it's a lot of doctors under the age of 40. So there's been a really nice culture medically here as well, which has been kind of a special place to practice, in my opinion.
Yeah, and I asked this question last time we talked, and I'll ask it again because you had a really good answer. If you could wave a magic wand and change one or two things about this region, this town, to make it even more attractive for physicians, what would you say?
Yeah, I mean, the things that the town needs and that we all need, right? And to make Antigonish attractive, and that would be better access to daycare and more access to housing, right? Daycare is a real issue, right? We were on a list, Holly and I, a year before we even came here, and then it took us a year to actually get into daycare after we got here.
It's a maddeningly long wait.
Yeah. So, and if you're trying to attract professionals that have young children, you need to have childcare in order to work, right? So that access really can limit recruitment. But as I said, I mean, I think that it's an issue for the town in general.
It's attracting anyone, not just physicians.
Yeah, exactly.
And for the people who already live here.
Yeah. And then and housing as well. I mean, housing is fairly scarce here, right? And actually, Sarah O'Toole helped us find our place, so we really lucked out. But that can be a real challenge as well, finding a home. If you want to buy a home, that can be a real challenge.
Yeah, for sure. So we're running up again to another 50-minute conversation. We talk a long time, you and I, but we could talk even longer, but we have to stop at some point. So I will ask you, is there anything we didn't talk about that you would like to mention, or you think people should know something about your world as a family doctor that we haven't covered yet? Or do you have a message perhaps for the people of Antigonish about life as a family physician?
I think just recognizing, there's a lot of limitations to the system right now. I mean, I think it's around 2,000 people the last time I heard in Antigonish that don't have a family doctor, which is a really huge proportion of the population.
Yeah.
And that puts a lot of strain on the emergency department, puts a lot of strain on the clinics locally. And it's a problem that we all recognize and know that, we need solutions for. And, we've been working very hard on recruitment here in Antigonish, and we're starting to see some fruits of that labor, I should say. But, I recognize it's very difficult to get access, and it's something that, we're still working on.
Yeah, and I had printed out some statistics when we're talking about the population on the list, so people without a family doctor. And in January 2025, it was 10.4%, so 1 out of 10 people did not have a family doctor. But a little over a year later, May 2026, we're down to 5.5% of the population. So that's great. So that's a big reduction. Obviously, that's not everybody because there's a lot of people.
That is a big reduction.
Yeah.
And the only thing that the numbers there don't capture is, pretty much everyone in Halifax and Dartmouth have a family doctor right now.
Yes.
And that's a huge slice of the populace. So once we start getting out into some of the more rural and remote areas, I would say, without having hard numbers myself, I bet those numbers drop off pretty significantly.
Okay. Yeah.
Right?
So there's a difference between HRM and...
Yeah. So I think there still are a lot of access challenges in more regional and remote settings. And that's why we see a lot of pressure, right, on the system, and why we have 15-hour waits in the emergency department, and why people are going 2 to 3 hours to different emergency departments in order to get more timely access, right?
That's right. Yeah, we talked about that at some point. Yeah. Popping over, I think Sherbrooke has a little office people sometimes go to. Is that right?
Yeah,
little
exactly.
ER?
Yeah.
Yeah, well, that is great. But I mean, things seem to be looking up. I mean, moving in the right direction, and I mean, you're busy with this as well.
Well, there's a lot of doctors in this town that work really hard.
Yeah.
And trying to sort of improve access and really make changes to the system. So, it's a really motivated group of physicians in this town right now. And it's there's a lot of doctors that I've been learning a lot from in terms of trying to, make those changes here in town and try to advocate for the community and this staff here at locally.
Great. Well, we'll end it there, good sir. I appreciate you coming back in for a second interview within 24 hours. We've now spent a lot of time. I think I spent more time with you than my wife in the past day. So this has been great fun, and thank you for all that you do as a physician, but also someone working in recruitment. And yeah, this was a pleasure.
Thanks for having me on, Justin.
Yeah, and good luck out there.
All right, thank you.
Bye. Thank you for listening to Let's Talk Antigonish. If you like the podcast, don't hesitate to subscribe. Just go to letstalkantigonish.ca and click. Voila! You'll receive new episodes right in your email inbox.
This podcast is a labor of love. Please consider making a contribution, small or large, maybe a monthly subscription.
A thank you to all of our supporters and subscribers, especially our paid subscribers through the Substack. You are really helping us to keep this podcast going, and we look forward to expanding it in the future. A huge thank you to Whidden Park Campground and HARP, the People's Press, two community sponsors of Let's Talk Antigonish.